Thank you so much, All India Society and Dr. Saurav, for making me a part of this interesting retina subspecialty day. We are discussing a very premium topic today, that is cataract, and with the advance in cataract surgeries and the premium IOLs that we are putting for our patients, let's not miss out subtle retinal conditions which can be the cause of loss of vision, and so much that we have to guarantee to our patients. So I'm going to talk about a very simple condition which has got very subtle signs, but it can cause definitely a loss of central vision or metamorphopsia. MacTel 2 or Para-Foveal Telangiectasia is an acquired vascular disorder of the macula, primarily involving the degeneration and loss of Muller cells. It was initially known as idiopathic juxtafoveal telangiectasia by Dr. Januzzi, but today with OCTA and OCT, it has changed the paradigm for us to diagnose this condition in even its absolute subtle form. As we go ahead to know what MacTel is, just a moment. Not able to go ahead. Yes. We know that's a bilateral hereditary disease, unknown cause, occurring in the age of about 40 to 50 years, with alterations in the macular capillary network and neurosensory atrophy, manifest mainly temporal to the fovea. Multiple signs that are seen in these patients from its initial subtle stages to the late stages. I'll be discussing all these signs while I'm showing the pictures of these patients with different different stages. But we must understand that when we have a patient of cataract, a fundus evaluation on slit lamp biomicroscopy, fundoscopy, if required, an angiography, OCT, and OCTA today are important investigations if we pick up something on the retina. Yes, if the cataract is dense, it's difficult at times to see the slit lamp biomicroscopy and fundoscopy, and their OCT stands a very, very important role. But if the cataract is grade 2, then we can pick up these signs. Coming to MacTel, if we see stage 1, on a fundus evaluation, we may just see a loss of the foveolar reflex, like a little blunting. OCT may show us a small enlargement of the foveal pit and sometimes these void cystic spaces. And on OCTA, you see just an early dilated capillary in the deep plexus. As we go ahead into stage 2, you classically get a grayish discoloration at the fovea with crystalline deposits, sometimes which are seen just para-foveal, temporal to the fovea. On the OCT, there is loss of retinal tissue, classically because of degeneration of the Muller cells. And on OCTA, we classically see these dilated capillaries, now not only in the deep plexus, but also in the superficial plexus. Go back to stage 3 from here, and here the patient now presents with a typical pigment plaque, which is temporal to the fovea on fundus examination. On the OCT, we see ischemia of the photoreceptor layer with a break in the ISOS junction, and thereby diffusion of the RPE, causing an RPE plaque or hyperplasia. And this is also seen on OCTA as an RPE atrophy and abdominal vessels which now merge with the atrophic areas. As we go to stage 4, we realize that in some of these patients on fundus evaluation, around the RPE plaque, we see a small foveal cyst, which can at times mimic a lamellar macular hole. On OCT, we see hyperintensities all through the RPE layer as the vessels migrate towards the RPE. And now in OCTA, we see that multiple abdominal vessels are migrating all around and merging with the choriocapillary strew. As we go to the last stage, which is stage 5 and the complicated stage of MacTel 2, patients in this case present with a classic CNVM subfoveal. On OCT, there is a classic type 2 subfoveal CNVM, but these CNVMs present with not much of subfoveal fluid. And on OCTA, you classically see a vascular net. So these are different stages. As we go from stage 1 to stage 5, yes, stage 1 and 2 are very subtle changes, and it's difficult to pick up these changes when we are seeing patients with dense cataracts. But in cataracts which grade 2, at least we can pick up these fundus stages. But as cataract goes advanced, OCT becomes a must in almost all our patients. This was another patient which presented like an early lamellar hole, but as soon as the OCT was done, we diagnosed it to be a parafoveal typical type 2A. So recent advances in cataract surgery have led to excellent outcomes, rapid recovery, and increased patient expectations. Utilization of premium multifocal IOLs reduce contrast sensitivity and increase our patient expectations, which makes thus the presence of any retinal thickness potentially very significant. In conclusion, and a take-home message is a very careful pre-op examination. Keep subtle retinal conditions in mind, which are difficult when we are seeing patients with cataract. And every time that a patient comes with cataract, the loss of vision may not only be because of the cataract, but be because of such conditions existing on the retina. OCT is a must in all premium IOL patients. Counseling, again, is an extremely important thing. And on the choice of intraocular lens is very important in view of pre-existing retinal condition, and a guarded visual prognosis should be given to all our patients with a pre-existing retinal condition.